First talk is by Paul Sorajja. He's going to talk about or debate about transcatheter therapy will compete with surgery for MR reduction.
Good morning, everyone. Thank you for being here. So Gaurav and I are going to have this back and forth a little bit, and this, especially given the size of the audience, this would be a great opportunity to have a discussion as well. So I'm here to talk about transcatheter therapy. Will compete with surgery for MR reduction. Here are my disclosures. I think it's important first to start by looking at exactly what the title of my talk is. It's about will. It's not about present state. It's about the future. And so that's what we need to focus on. But it is important to think about how did we get to this current state. And if we look back, it really was the EVEREST trial that set us up for the current indications and how we perceive transcatheter therapy versus surgery. And just to recap, many of you know EVEREST was 279 patients. Patients had to be eligible for CLIP or surgery. Most were DMR, and they were randomized 2-to-1 for CLIP versus surgery. And in the 5-year follow-up study, we know from the EVEREST trial that surgery is definitely better than transcatheter therapy with MitraClip for MR reduction. If you look at the 5-year outcomes, 3 or 4 plus MR, 12% versus 2% for surgery, and that's in the context of 28% of the patients who had MitraClip needing surgery at some point, compared to 7% with an reoperation. So that really is the basis for how we look at our mitral patients currently. And this is the current landscape. So if you look at these patients, so on the left-hand side, you have someone like Gaurav who can do port access, minimal scar between the ribs. It's a great result. It's appropriate for all patients to be considered. On the other hand, MitraClip on the right-hand side, you can only consider this therapy if the patients are at prohibitive surgical risk. But is it really that simple in terms of the dichotomy as to how we approach our patients? I would vouch that it really is not that simple. There are some interesting observations in EVEREST, and these aren't necessarily critiques. These are just observations that I think we should all be aware of. The SLDA rate was 5.6%. And all of these patients had surgery. 5.6% is almost unheard of nowadays with what and how we do MitraClip. Now it's only 1.5%. So you have to think about improvement in techniques, improvement in operator experience, improvement in patient selection, and the SLD rates are much better. So what we can do nowadays will have a lower rate of need for surgery. Another important observation is that there's no difference in the long-term mortality despite those differences in MR. And then finally, it's also important to think about the fact that 14% of the patients who had surgery actually had mitral valve replacement. But those events of surgical valve replacement were not counted as failed surgical repairs. They were simply just counted as surgery. And I would vouch that if somebody can't be repaired, that's unfortunate and would be a failure. We should always try to repair our patients, especially if they have DMR. So when you look back at the EVEREST outcomes and look at these data, and this is that same slide again, and if you add in the fact that 14% had mitral valve replacement, and think of that, well, the numbers are a little closer in terms of the endpoints, whether it's MR reduction or reoperation. It doesn't really make things equal, and certainly this is not a randomized thing, but it's just important to consider that in the context of what we're offering our patients when we're talking about mitral valve therapy, whether it's surgery or transcatheter therapy. The other thing I would say is that people like Gaurav, or I think I quoted you on this. I'm very special. He's a special guy. You know, if I had Gaurav...
Gosh darn it, people like me. That's what my parents tell me every day.
If I had Gaurav for everything I do, that'd be wonderful, but that's just not the reality. If you look at this survey, this was a survey that looked at 100 cardiovascular specialists who worked in valve centers, okay? Not even your general cardiologist or your primary care doctor, but 100 specialized cardiologists or cardiovascular specialists. And in this survey, 1/5 of them had concerns about access to mitral valve repair locally. I mean, that's mind-boggling. So if you imagine that that's what it is for an expert, think of what that must be for general cardiologists. And that's important, again, to consider what we were trying to offer our patients. Sure, if we could send every patient to a center that can do repair, that would be wonderful, but we all know that logistically, it's just not possible. And again, I go back to the fact that the 5-year outcomes were largely comparable in terms of survival. But another important observation is that most of the outcomes that were adverse in terms of MR and need for surgery occurred in the first 6 months. And if you look at a landmark analysis, after 6 months, the need for surgery reoperation was essentially the same. So what does that tell us? And what that tells us, I think, is that it really is about the acute reduction, because the acute reduction really predicts the long-term effect of what we do with MitraClip. So it comes down to operator expertise, patient selection, and getting the results that we need to get for this therapy. And there are various predictors of procedure success. Gaurav and I were authors on this paper. You know, in terms of MR reduction, the bigger the heart, the worse the MR, lower likelihood. But things like A2P2, very simple, straightforward type of pathology, extremely high rate of success. Another important predictor was case volume that speaks to operator expertise. And so these are the types of things you can think about in terms of selecting our patients, because you can get surgical-like results. So if you look at a patient like this, you know, look at this DMR in this 3D view, look in the lower left-hand side, there's this eccentric MR, single clip, 10 minutes done, and you look at the lower right-hand side, and I'm pretty sure Richard told me that this is trivial, though he will tell me what I like to hear. But you can tell that this is extremely gratifying in terms of what we can do for our patients. And we can do it even in challenging anatomy. So here's a patient with a previous failed surgical annuloplasty. Had this incomplete ring, we placed a clip even though there was no posterior leaflet and there's no residual MR. So in the right hands, proper patient selection, you can get really good results. And then the other thing I would mention is that when we look at MR as an endpoint, there are real challenges in how we assess these patients. We still don't know how to quantify MR after MitraClip therapy. We kind of look at the color, look at the pulmonary veins, we kind of come up with some idea. If it's torrential, it's really obvious. If it's absent, it's really clear. But in between, there are a lot of different shades. And if you look at a patient like this, which I showed last night at our dinner symposium, the LA pressure was 13. You know, this MR could be looked at as moderate, but what's the significance of that? It's very challenging in terms of determining what the significance of it is. Now, if you look at all transcatheter repair therapies, if you look at them across the board, they will not get surgical-like results. You know, the latest Cardioband data, similar to MitraClip, 2/3 of them could get something surgical-like, but a third of them will still have moderate MR, and this is true for all transcatheter therapies. Millipede is quite promising, but still in early stages, but I think it's pretty much true for all. And this is important because, you know, Gaurav will tell you that repair, the need for repair is recommended based on the likelihood of success. And so when we're looking at our catheter-based therapies, I think we do have to think more surgical-like. For the surgeons, their success rates determine whether they can do procedures, and for transcatheter therapy, I think it should be the same. I don't think it should be that, well, let's just throw in a clip because we think we can. I think it should be based on a high likelihood with a low operative risk. And that's the only way we'll be able to move out of the prohibitive risk arm, because when you look at the current landscape, there are two blue oceans here. On the left-hand side, there's a blue ocean for MitraClip. On the right-hand side, there's a blue ocean for surgery. They're not supposed to talk to each other. There's supposed to be one therapy for each of these oceans. But if we were ever going to have MitraClip or other transcatheter therapies move towards surgery, we have to get surgical-like results. We have to think surgery. Again, it's about case selection, operator expertise. We need to compare apples to apples. MitraClip is a repair technology, like other transcatheter therapies. It has to be compared to the surgical likelihood of repair as well, not replacement. We need better definitions of post-clip MR, and we also need ancillary tools. MitraClip has been criticized for being a single tool without an annuloplasty band and among other things, and those things will change. But I want to go to the expert here and just hear what he has to say about this procedure. Can we have the volume up here? Is there a volume?
Yes.
Okay. Well, I anticipated that could be a problem, but this is his interview on MitraClip. It is a great procedure in the right patient.
I did say that.
You did. So, but I think Dr. Al-Awwadi, actually, we agree completely. It's the right patient and selecting the right patient in addition to having the operator experience. So how about TMVR? And I think TMVR has potential to change this landscape. And again, we're talking about MR reduction. And if you look at therapies like Tendyne, so Tendyne, look at the top right-hand side. You put this valve in, there's no MR. I mean, not even a pixel. Look at the echo on the lower left-hand side, the same. And you can do this almost in the same amount of time as you do MitraClip, less than 45 to 60 minutes, skin to skin. Intrepid, similar. So if you look at this, this is a Medtronic Intrepid device. Look at the MR here, look at this. No MR. And again, procedure time, less than an hour for what we're doing here. There are challenges we're going to be overcoming with TMVR. We know that these devices have been criticized for screen failures. Looking at the Neo-LVOT, there are some patients like on the left who are better candidates than patients on the right. And we're figuring this out, and the devices will continue to iterate. But even among the devices that are being put in right now, the residual MR is so trivial, and the boundaries are being pushed. Many of you have already seen this over the past couple of days. This Tendyne valve being put in a patient with severe MAC. Again, a pathology that's incredibly challenging, but no residual MR when we're done. And when you look at the global feasibility study for the patients who are implanted, 26 or 27 had 0 MR, 1 or 27 had just mild MR, and success rates are very high with a low operative mortality. And when we put these in, so I asked what one of our surgeons thought of this. He'll go unnamed. And he said to me, why would I want to replace a valve any other way? It's easy, there's no MR, and the patients do well. And I have to agree, it's extremely enticing about thinking TMVR that way. And when you look at who's coming on board, so we have Dr. Al-Awwadi, National PI, this is a direct quote, I'm on board. And so we're all headed this direction. So thank you very much.